Good morning, everyone. Welcome to Child Neurology Grand Rounds. It's my pleasure to introduce our speaker today, Dr. Aaron Boes. Dr. Boes is a pediatric neurologist at the University of Iowa. He's an associate professor in the departments of pediatrics, neurology, and psychiatry, and he's the division director for child neurology. He also directs the UI Center for Non-Invasive Brain Stimulation. Dr. Boes is from Iowa originally and completed his bachelor's, MD, and PhD all at the University of Iowa from 1999 to 2009. He did his pediatrics training at UC San Diego and neurology training at Mass General Harvard University. He completed a fellowship in neuropsychiatry and non-invasive brain stimulation at Beth Israel Deaconess Medical Center, working with Alvaro Pascal Leon and Mike Fox from 2014 to 16 before returning to Iowa for a faculty position. A major focus of his lab is investigating the functional consequences of focal brain lesions to better understand the organization of the brain. He hopes this approach will help to inform treatment targets for neuromodulation such as transcranial magnetic stimulation. His research has been continuously funded by NIH since completing residency in 2014. Notable awards include the prestigious S. Ware Mitchell Award from the American Academy of Neurology for outstanding achievement in neuro research, as well as the Early Career Development Award from the American Neuropsychiatry Association. Please extend a warm welcome to Dr. Boes to address the audience. Thank you for joining us.
Thank you for the nice introduction. I'll go ahead and get started. Feel free to interrupt as I'm going along. So the topic for today is one of the main topics that my lab focuses on, which is developing a method to predict outcomes after stroke based on lesion location. And I think we're surrounded by a lot of wonderful prediction-based technology that we use all the time. You can find out what the weather is going to be over the weekend. You can find out how long it's going to take to, drive to a different city. You can get all kinds of really accurate types of information from the current technology that we have available. And I feel like that really hasn't been fully developed for things like stroke prediction based on MRI. And I think the research is getting to a point where we're ready for that. So that's what I'll be talking about today. And we do this already routinely for some of the easier problems that use brain MRI. So an example would be if you're covering ER consults today, you're seeing patients with new onset seizures and they have MRIs like this, you're going to be giving them very different sort of prognostic information and having a very different conversation with these kinds of patients. And I think that's a relatively easy problem based on the very obvious imaging differences between these two cases, but I think it's less obvious when you're talking about predicting long-term outcomes based on the location of a stroke lesion. So I'll give a few case examples over the course of this presentation, a couple of adults and a couple of pediatrics. So hopefully if we have adult neurologists and pediatric neurologists in the group, we can keep you both engaged. So the first one is an adult patient, a 62-year-old woman who is at home watching television and becomes confused using her remote control. And she's trying to tell her husband about this, who's there with her and has trouble coming up with the right words. Comes into the emergency room to report these symptoms, sees a neurologist consultant. They do an NIH stroke scale, which shows only that deficit with some word finding difficulties, otherwise completely unremarkable. Goes for an MRI, and she indeed had a new onset ischemic stroke that you can see there in the left periventricular white matter. And as I'm sure you all know, it's a very common occurrence, 5 million strokes per year, about 800,000 in the US alone. I imagine anybody who's covering the stroke pager at your institution will be seeing multiple strokes over the case in the next 24 hours. And a common question for these patients is, what can I expect? Is my speech going to come back? And it's a difficult question to answer. I think, we all come up with strategies as neurologists about how we approach this question, but it's a really challenging one. And I feel like there aren't good empirical tools available to support us in giving really good, accurate information to patients like this. So how do we do it currently? I would argue that we really take, the patient's current functional status and our knowledge of the neuroanatomy of the lesion and similar patients that we've seen and try to make a best case guess. And for this particular woman, even though her symptoms were quite mild at the onset, she discovered over the next 3 or 4 months after the stroke that she was really struggling cognitively with a lot of things that she was previously quite skilled at. So she was managing a farm in terms of the accounting bookwork and taxes and ordering supplies and things like that for their family farm. And she just wasn't able to keep up with those tasks and was referred for neuropsychological testing, which I just copied some of the report here. But she had really severe impairments in multiple domains of left hemisphere function, things like language, verbal reasoning, arithmetic, working memory, retrieval of new memories, visual processing, finger localization. The neuropsychologist who didn't have access to the imaging really thought this was consistent with the pattern of widespread left hemisphere dysfunction, which is not probably what most people would have predicted based on an NIH stroke scale of 1 and a lesion that looked relatively small. And I think that this case really highlights 2 limitations of current stroke management, which is the NIH stroke scale lacks sensitivity for cognitive deficits, and we use that to make important decisions about interventions in the acute period. And then it's difficult to give people accurate and personalized prognostic information currently. So this is where I feel like the type of lesion research that my lab does that is popular at the University of Iowa can really be translated to improve care for patients like this. I think there's a treasure trove of clinically useful information that's just waiting to be unlocked from each brain MRI that shows a lesion location. And the following slides will really kind of walk you through how I think that can happen. But this is a nice, really basic schematic, which is somebody comes in with a new onset stroke. You can segment exactly where that stroke location is and then move it to a template brain, which has other information embedded within it. So for example, lesion symptom maps of different functions. And this is one that you can see here that intersects directly with this woman's lesion that I'll be talking about in the next few slides. But this is a lesion location that was associated with general cognitive deficits across a large cohort of individuals. So I think based on a paradigm like this, you could make predictions about different functional outcomes and then use that to inform things like TPA. Maybe even though this woman only had a NIH stroke scale of 1, she would actually be a good TPA candidate, given that this is a lesion location that was associated with high risk for cognition based on some of our prior research. And then, this same exact tool could be used to give this woman helpful information, like she may find herself struggling to do some of the cognitive tasks that she could do previously and engage in cognitive rehabilitation early on, and maybe hand off some of those duties that are most demanding to other people. So I think one of the really foundations for making good predictions from stroke is based on the lesion location. We've known for a long time, more than 150 years, that lesion location really matters a lot in terms of predicting deficits or being associated with deficits. This goes back to Broca's work of 1861. And the lesion field has kind of been continuously doing research ever since, and our methods have gradually gotten better over time. So this is kind of a basic diagram of how we do lesion symptom mapping studies today. So we start with a broad group of individuals, some of whom have a deficit, some of whom don't have a deficit. They all have brain scans showing some region of brain damage. They all have some behavioral performance information, whether it's a clinical syndrome or performance on a specific neuropsychological task. And then we can use various statistical software packages that relate the lesion location to the deficits of interest. So that can be done based on binary variables in terms of behavior or continuous variables. And there are a lot of different approaches for doing this, whether it's on a voxel-wise basis or multivariate basis, or new machine learning algorithm approaches, deep learning algorithm approaches. But they basically all get at the same thing, which is relating lesion location to specific deficits across specific symptoms. And we're at a really good position to study this at the University of Iowa, which was a big part of my motivation for returning to my home state. We have a lesion registry that's been active since the 1970s. Arthur Benton was one of the founding fathers of modern neuropsychological assessment and very interested in lesion location. Then Antonio and Hannah Damasio moved to the University of Iowa in the late 1970s and stayed on through about 2005, 2006, and developed this really world-class lesion registry. We have more than 4,000 individuals who have enrolled in the research. More than 1,000 have modern MRI imaging lesions that have been manually segmented, really extensive cognitive outcome data with full neuropsychological testing. And then Dan Trinell is our director of neuropsychology, who's currently overseeing it. So I'll talk about some of the research today that informs that case that we just saw. And this starts with Mark Bowen's PhD research. So he was my first graduate student in my lab. And he was interested in predicting general cognitive ability after stroke. So general cognitive ability, or G, is essentially, you can think of it as I guess, if you think of high school academic performance, you can sort of consolidate that into a single value at the end of your 4 years, which is GPA. And I think of G as sort of a similar estimate of overall performance across a wide variety of neuropsychological tests. So we had 402 individuals who have all taken a full neuropsychological test battery with about 16 different neuropsychological tests. And G was derived from structural equation modeling, which is essentially showing an estimate of which measure can explain the most variance across all these different tests. So the first question that we could ask with that, after deriving G from these various lesion patients, is what cognitive construct relates most closely to G? And you can imagine different possibilities, like it's language-based or working memory-based or processing speed-based, or all kinds of different possibilities. But what the data suggested was that it was really most closely related to working memory. So the ability to hold information in mind and manipulate that information, really closely correlated with things like doing mental arithmetic or digit span. And then the main focus of his PhD research was trying to localize regions in the brain that were most associated with broad cognitive deficits or impairments in G. And this is the lesion symptom map that he derived from those 402 individuals. And you can see this periventricular deep left hemisphere white matter was the peak finding of everywhere in the brain. And my first thought for this was, it might relate to large MCA territory strokes, and that this is just sort of on the periphery of the MCA distribution. So perhaps it's just small lesions or just huge lesions, and that's what's contributing to the widespread deficits. But we found several individuals who overlapped with that region who had relatively small lesions, and they were pretty much impaired across the board. You can see on the right side, just overall performance across those individual neuropsychological tests. So if this was a true finding, and I feel like there's reason to be skeptical, right? So that you can localize something like general cognitive ability, which isn't going to have a defined circuit that evolved probably per se, it probably involves multiple different functions. But if this was a true map, we should be able to use it to predict cognitive deficits in a completely separate out of sample cohort. So that was our next step in this project. We got the help of Maurizio Corbetta at Washington University and used their stroke cohort that they had acquired there to see if we could predict deficits in G. And it had reasonable performance here, you can see. So first of all, we had to estimate G from a completely different battery of neuropsychological tests, and then see if we could predict it based on lesion location. And that was a Journal of Neuroscience article from Mark in 2020. And then jumping forward to current efforts, one of the things that we've been very interested in is, can we use connectome data to make stronger cross-cohort predictions? So the idea here is that focal lesions are really not all that focal if you think about them in terms of, they're disrupting network information flow. So in the same way that airline traffic across the world relies on specific hubs, and if you have a shutdown of O'Hare Airport or LaGuardia, it's going to be much more damaging to widespread airline traffic than a small region like Cedar Rapids Airport, which is our local airport here. So everything's connected, and you're going to have downstream effects based on lesion location. And can we take advantage of that knowledge and new resources that are available for neuroimaging research that map out sort of normative patterns of connectivity, and can we use that to inform lesion-related deficits? So I'll jump back in time here briefly to a project that I did as a resident, which ultimately led me on this pathway of integrating connectome research with lesion research. And that started as a second-year pediatric neurology resident at MGH when I saw a 17-year-old girl who had the chief complaint of seeing things. So she was a healthy girl, straight A student, captain of her soccer team, and driving her car one afternoon and started to experience strange visual phenomena. So the first thing that she noted was that her vision was going in and out of focus as if she were looking through a zoom lens. And then she said the scenery as she was driving along looked as if it was being colored in with crayon as she was driving, and she saw animated creatures walking on the sidewalk, and pulled over, stopped driving, and reached for her jacket before she left her car. And she said as she was reaching for it, it was in the passenger side on the floor, and it sprouted out flowers. And as she pulled the jacket away, all the flowers fell over and their stems were straight like popsicle sticks. So she gave this very vivid account of all these different strange visual hallucinations that she experienced over a period of a couple of hours. Went to an outside emergency room, was evaluated, everything seemed normal, CT was normal. She came to see us at MGH as a follow-up for that. And we got an MRI that showed a relatively new stroke here that you can see in the left central thalamus. And that was a case of peduncular hallucinosis, which is something that I hadn't seen at the time. So this was described by Jean Lermite in 1922, I believe, predominantly visual hallucinations that can follow a brainstem or a thalamic insult. It's often thought to be a midbrain phenomenon based on the first case that Lermite described. So this was presented at our neuroradiology conference on one of the first days of my research elective, and I was looking for a project anyways. So the question I had was, does peduncular hallucinosis localize to specific brain regions? And I acquired every case of peduncular hallucinosis that I could get my hands on, which included some local cases at Boston, as well as just a full literature review, and pulled every brain lesion location from figures that I could find and mapped it onto this template brain. So this was the full spectrum that I could find in 2013, 2014. 23 cases, and what we found was that there are different sites of lesion overlap that were associated with peduncular hallucinosis. The peak region was actually in the thalamus, right thalamus. In our case, the 17-year-old girl had a lesion in the left thalamus. And that was basically kind of a case series that I was working on writing up, but it wasn't fully satisfactory in the sense that these are not visual regions of the brain. They don't really explain the visual hallucinations that these people are experiencing. So there must be more to the story. So at this stage, the hypothesized mechanism for peduncular hallucinosis has been around for a long time, is that there are these subcortical sites that, when damaged, cause release hallucinations. So it's a cortical phenomenon, but that the cortical regions that mediate the hallucinations are normally under the influence of subcortical regions. And when that influence goes away, that you have these release hallucinations is one of the ideas. So at this stage in the project, we got involved Mike Fox, who was an expert in resting state functional connectivity MRI, and wanted to ask the question, what is the connectivity pattern of each one of these lesion locations? Maybe that can help us explain why these are presenting visual hallucinations. So the approach was pretty straightforward here. This is the original 17-year-old girl who had those symptoms. You can see her brain mapped onto a template brain here, or a brain lesion, and then entered as a seed region in a functional connectivity analysis, which shows basically regions that are coactive or have lower bold responses at the same time as that region. So across time, you get a map of brain regions that are functionally coactivated, and you can map that, and then you can overlay all those different lesion-associated networks in the same way that you did the lesions themselves. And when we did that, we had this really interesting finding, which is that 22 out of the 23 cases had a lesion-associated network finding in this region of extrastriate visual cortex that's been implicated in visual hallucinations. So we were excited by this as a methods-based article because it could actually help us think about things like diaskesis when we don't have advanced imaging of the participants themselves. So we worked for a couple of years developing this approach. We applied it to different lesion syndromes and then ultimately published it in 2015. So then I'm going to jump forward now 7 years later. So that was my residency project. And then we're still using that approach now, but we're trying to think about whether or not we might be able to use it to enhance our prediction of stroke-related outcomes. So this is a 2022 paper with Mark Bauern as the first author. And I think it's kind of the best overall representation of where we're at right now in terms of making lesion-associated predictions, in my lab at least. So we do lesion behavior mapping, first of all, or lesion symptom mapping. And then we take the regional peaks, those regions of the brain that are most heavily associated with deficits across individual functions. And then we use those to seed network maps, whether they're in gray matter. If they're gray matter, we use functional connectivity MRI. If they're in white matter, we use structural tractography. Again, these are with normative data sets to derive the networks. And then we can see if those derived networks are actually helpful in making predictions. So that's what Mark did for this brain paper. This is a busy slide, but on the far left side here, we have the lesion symptom map association. So across things like expressive language, receptive language, a memory test, and a motor test. And then on the right side, we have out of sample prediction. So we use this information to try to predict outcomes across the WashU cohort. If we just use lesion symptom mapping, so just lesion location, we get an okay out of sample prediction in the range of like 34% of the variance explained for expressive aphasia, for example. And then if we incorporate lesion network mapping, the networks associated with these regions, it improves quite a bit by more than 10% of the variance. So that was encouraging that we can actually improve upon our standard original approach of thinking about lesion location as a predictor and incorporate lesion associated networks, and we get better predictions. So we can apply that same thing to G. Mark had that original 2020 paper looking at G and its lesion location, which showed that deep left hemisphere white matter region. What about the lesion associated networks? So we did that both with functional data and with structural data and came to the same basic conclusion, which is that there are these regions of the occipital temporal region, parietal, and some dorsolateral prefrontal that are most critical for supporting G. And this aligns really well with the dorsal attention network in terms of canonical functional networks that have been described previously. So he has currently an article in prep with these findings. And then if these are true and valuable, then we should be able to improve upon our predictions in out of sample cohorts, right? So we have now 2 validation data sets. We have Mark's original lesion symptom map of G. Now we have these lesion network maps of G derived from functional and structural data. And the question is, do we improve upon our earlier predictions of G and out of sample groups? And interestingly, when we do these models, the functional network map doesn't really add value. It's really the white matter and the lesion behavior map data that adds the most. But our predictions are getting better. So you can see this is a prediction in WashU, which is higher R than it was previously from our original paper, which just used the lesion location information, and then same for our clinical data predictions. And then a natural question that came up with this original finding from Mark of this deep white matter region in the left hemisphere that seemed to be so critical for cognitive outcomes. What's going on there? And I think one of the clues came from a different paper that had a different focus, but ultimately pointed us in the same direction. We looked at different measures of hubness across the human brain that have been defined in normal healthy individuals. And people can define hubs in the brain using all kinds of different mathematical formulations, and they can do it in gray matter and they can do it in white matter. And nobody really knows which of these hubs is the best definition, most predictive of cognitive deficits, for example. So we use the lesion registry data as a method essentially of comparing different hub measures and seeing which one was the most predictive of different cognitive outcomes. And when we did this, we found that the white matter hub measures outperformed gray matter, and that this was the best predictor overall of general cognitive ability, something called edge density, an edge density map. And it basically shows the number of streamlines connecting different gray matter regions. So if you have a major intersection region in the brain that has white matter that connects a lot of different regions, then it's going to be brighter yellow on this map. And that showed that essentially that left periventricular region is one of the strongest findings of anywhere in the brain in terms of maximum number of white matter connections. So I think that might help to explain why that region is so critical for cognition. So to summarize, so far, we've got this left periventricular region. It's really strongly associated with broad cognitive deficits. It can independently be used to predict cognitive impairment in secondary samples, both from Iowa and Washington University. And this is a region of the brain with the highest density of structural connections. And then, still being skeptical, does it replicate in a brand new sample? That's pre-registered in terms of our hypotheses in the region of interest. And that's work that Jamie Kaminsky did for a rotation project. And we have 142 stroke subjects. We just did a very, very simple analysis, which is, do they intersect with this high region or not? And if they do intersect with a high risk region, we predict that they're going to have worse cognitive performance than those who don't. And we defined that based on the number of impaired tests as a percentage of the neuropsychological tests that they completed. And there was a pretty obvious statistical difference between those two groups, showing that if your lesion intersects with this site, you're going to be performing more poorly across the neuropsychological test battery. So I think the way that you can imagine this all influencing patient care is this patient comes into the emergency room, has her MRI, as she did already. You see the lesion on the MRI scan, and instead of just leaving it to the devices of the interpreting neurologist or neuroradiologist, you actually have an empirical tool that looks at the lesion location, compares it to lesion symptom maps that have been developed in these types of studies, and provide some additional information about the patient's lesion. And then you can use that to make decisions about TPA. You can incorporate that information into what you already know and make decisions like whether or not to deliver TPA. You can use it in counseling the patient as you're discharging them about what sort of rehabilitation strategies might be useful, what sort of tasks might be difficult. So the main hurdle left to overcome to make something like this clinically applicable is, I think, automated lesion segmentation. So everything that I've presented thus far has involved, people manually segmenting every single slice of an MRI to show where the lesion is. And I think that process would have to be fully automated for this to ever be useful clinically. I don't see radiologists, for example, tracing these lesions, which can take hours for some large lesions that are difficult. So for taking on this task, we're working closely with engineering, with Hans Johnson and his graduate student, Michal Bruce. And the idea is that we're going to use a deep learning algorithm to do this in a fully automated way. And we're a few months into this project and having pretty good success already, where we can delineate an acute stroke from MRI in a fully automated way. we're also collaborating with Siemens. They have their own algorithm to detect acute stroke and seeing how the two compare to each other. So our next steps for this are we just pulled 1,000 clinical MRIs showing acute stroke, and we're going to continue training the model and see if this gets better and better over time. We're just applied for a grant that would fully automate this process of pulling raw DICOM data and translating it into a text-based output regarding predicted functional outcomes across different domains. So that's one story. I'll jump over to a pediatric story. A 4-year-old girl who has progressive headaches a couple of weeks after falling from the monkey bars. She has an MRI of her brain as her headaches aren't getting better. After a couple of weeks, they're actually getting worse. And you can see this mass in the cerebellum. And she went to surgery the next day, uncomplicated, complete tumor resection. You can see the location of the lesion here. That was a later scan. And this was the histology. So multiple highly cellular primitive blue appearing cells consistent with medulloblastoma. And where this gets interesting is she had a really difficult post-surgical course where she had dysconjugate gaze. She was agitated, irritable, stopped speaking, was just persistently crying, moaning, intermittently following commands. And she was diagnosed with posterior fossa syndrome. This is variably described as cerebellar mutism syndrome, cerebellar cognitive affective syndrome. Different groups call it different things, but the idea is that you have often severe cognitive deficits and language deficits and affective changes after a cerebellar tumor resection, which is relatively common. It's like 25% of the individuals who have this surgery can have this post-op course. And hers were long-term. So she was seen 3 months later. She was still non-ambulatory, mute, was just communicating by crying and screaming. This was a girl who was previously talking. So cerebellum is the most common location for solid tumors in pediatrics. We're getting better and better at treating these patients. So survival is increasing, which is a good thing. And it sort of shifts where we need to focus our efforts, which is on avoiding long-term adverse outcomes from these cerebellar tumors. About 25% will develop these severe cognitive and affective symptoms at the time of tumor resection. And as I mentioned, it goes by different names. The reason the acute symptoms are important is because they can predict long-term outcomes that are worse for these patients. In my K-12 research that I did upon coming to Iowa was based on this hypothesis that there's an anatomical bottleneck. The cerebral cortex communicates with the cerebellum, and there's a massive amount of information that flows through this pathway of cortex to cerebellum, back to cortex. But it all is essentially anatomically converges in the outflow pathway from the deep nuclei of the cerebellum out through the superior cerebellar peduncles and route to the brainstem and thalamus. And so a very small or relatively small lesion can disrupt a lot of network activity in the brain. So we tested the hypothesis that lesions that affect the cerebellar outflow pathway are going to be associated with worse cognitive and affective outcomes. So we looked at this question in 195 individuals with cerebellar tumor resection, all children. They all had post-surgical MRI to show us where the tumor resection cavity is. And they all had post-op behavior, admittedly crude in that it was, did they have posterior fossa syndrome or did they not, based on clinical notes. And did a case control design. So each individual with severe cognitive outcome problems was matched to 2 control subjects who didn't. Fatima was a research assistant in the lab doing this work and had to painstakingly trace each one of these 195 lesions onto a template brain. And when we did that, we quantified how much each individual lesion overlapped with the cerebellar outflow pathway. So these deep nuclei out the superior cerebellar peduncle en route to the thalamus, and show that there's a clear statistical difference between these 2 groups. And that the rate of having these cognitive deficits actually relates to the extent of cerebellar outflow pathway damage. And we did data-driven multivariate lesion symptom mapping, showing that of anywhere in the brain, it's really these deep nuclei in the cerebellar outflow pathway regions that seems to be most heavily implicated. It was really the vestigial nucleus which had the strongest finding of anywhere in the brain, this cohort. And then we are just in the late stages. We have a paper under review that independently replicates this in a new cohort of 56 subjects. We had our hypotheses pre-registered this time and the analytic approach. And I think that, and we had the same finding basically, that the cerebellar outflow pathway lesions are the ones that are associated with the higher risk of mutism and cognitive deficits. So I think that presents an opportunity, which, if we know the structures that are most critical, we might be able to use that information prior to the surgery and use MRI guidance, and perhaps I could change the approach or change the invasiveness of the tumor resection around those critical regions. Or if nothing else, if it can't change the surgical approach, at least it could change how we present information to the families about the risk of having these types of deficits, because it's not 25% across all subjects. It's quite different if you have a lesion in a single hemisphere out in the periphery of the cerebellum versus in the midline and the deep nuclei. So that you could stratify risk basically based on lesion location doing this. And closing in here, I think this might be with the last case to discuss. 60-year-old woman who I just met a few weeks ago, 6 months after her stroke. She was enrolling in our research program, so I just stopped by to chat with her for a few minutes prior to her starting her neuropsychological testing. And she had a pretty focal stroke that involved the left insula. And spontaneously, she reported, it's the damnedest thing. I haven't smoked a cigarette since my stroke. Haven't had the desire to. I didn't try to quit. It was just like my brain forgot I was a smoker. I never had the urge to smoke again. So that was a neat report that was spontaneous, and it was perfectly aligned with the paper that we just published recently in collaboration with Mike Fox's group, which is that lesions to a circuit that is very heavily involving the insula is associated with a disruption to various forms of addiction, but most of the data was from smoking addiction. So that was just a nice anecdote that was aligned with a much larger study that we just recently did. And then I also was curious, based on her lesion location of the left insula, how her mood has been, if she's experienced any changes in the months since her stroke. And for that, she became tearful, and she said, it's a complete change from her pre-stroke baseline, and that every day is a struggle to find the will to stay alive because her mood is so low. She's been quite depressed, and that's something that she struggles with on a daily basis since her stroke. And the reason I asked her about mood was because we had just published this paper, which looks at more than 500 individuals who all had post-lesion ratings of mood, and the insula was the strongest association of people who are reporting lower mood. So this was a lesion that was a perfect hit to that lesion symptom map. And I think the reason that was insightful for me is that she spent probably 3 or 4 months dealing with these and was not very comfortable talking to people about it. She's not somebody who had experienced depression. She felt there was a stigma associated with these kinds of symptoms that she was experiencing. And she ultimately was able to get a referral to psychiatrists, but she still hadn't seen them. This was, several months after her stroke. And I think if we had a system in place like this, where we're relating lesion location to commonly associated types of symptoms, I think it would have opened the door for a patient like this to report that she's feeling sadness and suicidal ideation much earlier, and she could have got help earlier. She was tearful when I showed her the paper that this is, a known phenomenon, and she felt like that validated what she'd been experiencing since the stroke. So I think those are the kinds of cases where this could really be impactful for patients. And then a final slide here that's not related to the lesion work that we do in the lab, but I'm also very interested in non-invasive brain stimulation, neuromodulation more generally, and how we can use this type of anatomical information that's derived from lesion studies to inform our treatment targets for using things like TMS for different diagnoses. Right now, it's primarily used to treat depression, but there are a lot of opportunities for TMS to be used for other indications and neurological indications as well, things like central pain, stroke rehabilitation. I think there's a lot of exciting possibilities. And I've been interested in TMS since 2013, 2014, and did a fellowship on this topic. I'm very involved clinically in our program here. But one of the big limitations is that we really don't understand yet how TMS modulates the brain and how to, if we had a better understanding of the mechanism, I think we could get closer to improving our treatments in a more rational way. So the approach that we've taken at Iowa is to do TMS in neurosurgical patients who are doing phase 2 monitoring and have a higher resolution, both temporally and spatially, to evaluate the evoked responses to TMS. So we're doing TMS primarily in the left dorsolateral prefrontal cortex, which is the site where we stimulate for depression, and just asking the question, on a brain-wide basis, where are we seeing the evoked responses from TMS, with the idea that we're probably affecting a broader network. And this can give us information about what that broader network is. So we have a preprint out right now. We still haven't published our first paper on this approach, which uses TMS in conjunction with intracranial EEG. But our first analysis is showing that we're getting really strong evoked responses in the anterior cingulates, as well as the anterior insula, and aligns well with the salience network, which is the same network that showed up in this lesion network mapping study, which the salience nodes of the brain were associated with higher levels of depression after lesions. So those two are aligned in a sense. So I'll close with this, which is where I think we're at in neurology in terms of, for a long, long time, more than a century, we've used history and physical exam to make hypotheses about lesion location. And then since imaging has developed, we've been able to test those in relatively real time. And I think in the coming decades, one of the really exciting things that's going to happen is this is going to be a bi-directional pathway. We're also going to be able to use lesion location to inform how we take our history and how we perform our exam. I think there's not enough time in the day or for an appointment to test everything in great detail. But if we know that a lesion location is associated with depressed mood or working memory impairment or things like that, we can dedicate more time to assessing those things in clinical setting, dedicate more rehabilitation efforts to those things that are most likely to be affected. So I think there are a lot of opportunities to improve clinical practice, as well as improve study design for things like rehabilitation trials. So with that, I'll thank my lab who've done all this work, and I'll stop there. And if people have questions, I'd be happy to take them.
Yes, Brian and Ziska, professor of neurology downstate. Working memory, do we have any ideas to the networks involved specifically with working memory, and how does this relate to the classical PAPE circuits, etc.?
Yeah, it's a good question. I mean, the best information that I have for you would be related to working memory as broadly constructed across different tests with a latent variable. So we've looked at tests that require working memory, like digit span, performing mental arithmetic, Benton visual retention task. And if you derive a latent variable of working memory from those three tasks, the lesion associated correlates that we see as the strongest predictors across our data set is really the dorsal attention network. It's essentially that map that was associated with G. So there's a region in the deep left hemisphere white matter. It's generalized, but dorsal attention network. And I can't say about the PAPS circuit in terms of, like, I feel like our lesion coverage is lower there. We have a lot of hemispheric lesions, but that's where we're seeing the results.
Hi, Steve Spar. Just a quick question. Your subcortical, let's call it G spot,
Yeah.
seems to be just south of the angular gyrus. Does that give us any insight into the disparate findings in Gerstmann syndrome? Is it perhaps that Gerstmann is not a cortical phenomena, but a subcortical network phenomena? It's a mystery that's been there for 100 years.
Yeah. Yep. It's a great question. And you're right about the location. It is just deep to the inferior parietal lobe. Yeah, I think that that is likely a disconnection syndrome. And I think that the region that's showing up in our analysis is likely a massive disconnection phenomenon when you see deep subcortical lesions there. But I don't know if we have the ability to look at Gerstmann syndrome specifically in the lesion registry. Probably the best way to do it would be for us, would be like pulling cases from the literature of good, clean cases and then mapping those lesions onto the template brain and doing this kind of lesion network approach. But I think you're right in that it's disconnection syndrome, probably related to white matter, and it's not far from this site.
And just a secondary question. My old friend and colleague Jeremy Schmaman has done a lot to point out the effects of cerebellum on cognition.
Yep.
And I think your work supports that. I mean, we don't think of cognitive issues with cerebellum; we think of motor issues. But
Yeah.
Would you agree with his hypothesis that there's an awful lot of cognition taking place in the cerebellum?
I would. Yeah. I think it's most pronounced in children, to be honest. Like at least in terms of chronic impairments, I feel like adults tend to recover better. There might be some mild cognitive deficits acutely, and they often get better with time. But I feel like children can be really affected severely, much more so than adults. And I think it relates to the cerebellar's role in learning. But absolutely. I mean, I think it supports Jeremy's work for sure.
Thank you. Great talk.
Thank you.
I have a question.
Yeah.
Are you studying children with autism? Because one of the biggest mysteries is on the imaging MRI, we always find that there is cerebellar, shrinkage or atrophy, for lack of a better word, and saying, how does this fit in with their severe cognitive difficulties? So yes, cerebellum plays a big part, but what is it and how do we try and understand it?
Yeah, it's a great question. It's a great topic. So a few things that I'll say is one is Alex Cohen at Boston Children's Hospital is really setting up a lab now, or has a lab now that's focused almost exclusively on this question that relates the work that I talked about today to autism. So he's very interested in using lesions to identify specific symptoms that contribute to the autism spectrum. So I think that's a really interesting research program. Definitely there's a role for the cerebellum in autism based on some of the prenatal lesion work. I think Limperopoulos has done some of this work showing that there's a higher risk for developing autism spectrum disorders after prenatal cerebellar lesions.
Tell me his name one more time, please.
Alex Cohen.
Alex Cohen. Okay.
Yep.
Thank you.
Yeah, he's doing exciting work there, and I think
we'll try and contact him and learn more about it. Okay.
Yeah, sounds good. And then one other comment that I'll make is we are interested in the possibility that cerebellar transcranial magnetic stimulation could influence autism spectrum symptoms. So we had a small grant to study that. It's been challenging to recruit patients for it, so I don't feel like we have results to report yet, but we have a very small pilot trial where we're doing theta burst stimulation of the midline cerebellum in people with autism spectrum to see if there's any improvement in symptoms.
Wonderful. Thank you for a wonderful lecture.
Oh, thank you. All right, have I exhausted the questions?
Seems like there are no more questions, so we could wrap up now.
All right, well, thank you all.
Thank you for this fascinating talk.
Thanks.